Clostridium difficile is a very important pathogen, and it's one that's been very annoying because it hasn't gotten away, even though we've done a lot of research on Clostridium difficile. We know a lot about it, but it persists, and it lives up to its name. It is a very difficult pathogen. The burden of Clostridium difficile has continued to increase despite our best efforts. In the United States, we're approaching about 500,000 cases every year. So it's a very big burden for healthcare. About 30,000 deaths per year are attributable to Clostridium difficile infections, and about 83,000 patients that have C. difficile go on to have recurrent C. difficile, which is repeated episodes of Clostridium difficile. And if you're a patient, this is very frustrating. If you're a physician, this is very, very important and very difficult to control. On a facility level, Clostridium difficile has become the most common healthcare-associated disease. It even now surpasses MRSA in staph infections. It causes hospital outbreaks, which are very difficult to control. And it also results in increased healthcare costs to the facility. On a patient level, it increases the length of stay, anywhere from 4 to 14 days in a hospital, which is an enormous amount of healthcare costs. There's a higher attributable mortality from 5 to 17%, so it increases your chance of dying. And there's also, interestingly, a higher risk of acquiring another type of nosocomial infection while you're in the hospital. So, and the ribotype, Clostridium difficile has become very, we were dealing with Clostridium difficile about in the early 1990s, and with the advent of vancomycin and metronidazole, we were able to treat it, and so the interest sort of waned. And then in the year 2003, a huge outbreak in Canada resulted in high mortality, and this was due to the ribotype B027. But what we found that it's not a Canadian specific strain. It's actually being found all around the world. It actually started in Europe and then spread to Canada. But I want to urge you that it's not just, even though it's called a hypervirulent strain, it produces more toxin and more deaths are associated with it. This is not the only strain that you're going to be introduced to in your career. You will see other strains. Other strains are now circulating. Some strains are more prevalent in different countries. So it's not just a strain-specific problem, but we have different strains. So what's been different since that outbreak? We have found that the risk factors, we used to just say, oh, well, Clostridium difficile is a hospital-acquired infection. It's only very important to really study the hospitalized patients. And the risk factors that increase your risk of getting infections relate to host factors like increased age, other comorbidities, medications that you get, not surprisingly, antibiotics, things that disrupt your microbiome. Some procedures like surgery and nasogastric tube feedings also increase the risk. And pathogen exposure, the longer you stay in the hospital, the greater the chance that you'll be exposed to C. difficile spores, and so the increased risk that you'll get the disease. But what we're finding is that there's an increase in community Clostridium difficile, and the risk factors are slightly different. The host factors are the age is a little younger, and more females are developing C. difficile in the community. The medications, interestingly, antibiotic exposure is less important in community onset and acquired C. difficile, and there might be an association with proton pump inhibitors. And the pathogen exposure, so where do these people get and acquire C. difficile? It's basically they have a housemate that has had a prior C. difficile exposure. It increases your risk of acquiring it. Also, we've linked Clostridium difficile to the pets. So your friendly little dog and kitty that looks so cute can be carriers of Clostridium difficile. And it's also everywhere, so it's sort of tough. So it's been very interesting to kind of watch the emergence of community-acquired C. difficile. So how do you diagnose Clostridium difficile? We've learned many things along the way. The first thing is that we realized that, we used to just test for the toxin, and if you had a toxin positive test, you go, okay, this person has C. difficile disease, and then we would start treating them. Well, what we're finding is that in the hospital, about 50 to 60% are asymptomatic carriers. So you want to stop at that point. We don't treat asymptomatic carriers. We don't even test them for C. difficile. So it's unlike many diseases where you have a lab test that if it's positive, then you have the disease. Many people carry Clostridium difficile and are asymptomatic, and it actually increases the risk of them developing disease if you disturb their microflora with treatment that they don't really need. So it's a two-step process for diagnosis. It saves a tremendous amount of money and time when you don't actually submit a form stool to your laboratory for a C. difficile toxin test, and actually many labs will not test a form stool. So your first step is to have a patient with diarrhea, and then you have to realize that the spectrum of disease is very broad. About most of the people, 25 to 35%, only have mild to moderate C. difficile strains, but you can go on to develop very severe C. difficile. About 3 to 10% develop colitis, and here you see, this is, it's a very inflammatory disease, and the toxins result in a release of inflammatory debris. This is pseudomembranous colitis, where you actually have the exudate is so much, you have these lovely yellow to white plaques. So that's pretty characteristics of Clostridium difficile disease. And only, fortunately, less than 1% of patients actually go on to have ileal preparation, or they have developed sepsis or toxic megacolon, and less than 1% actually require surgery. So how do you, once you have a patient with diarrhea, what's the next step? So you want to actually, it's always a toss-up because you want to know the answer quickly, but you want the right answer. So the gold standard has been looking for the cytotoxin assay using cell culture. But the problem is that takes 2 to 3 days to actually get the result back. So people don't want to wait, and so these very rapid tests have become developed, and they have benefits and they have some problems with them. So let's just quickly review. This is a nice two-step process. So initially you have a patient and you test it with either the NAT or the glutamate hydrogen test, and this doesn't test for toxins, but what you're doing is testing for the presence of Clostridium difficile. If it's positive, then you can go ahead and use a more specific toxin test. If it's negative, you have to you might want to put this person as a suspicion, but you can't just stop at the first step where you're just saying that yes, this person has Clostridium difficile. There are strains of C. difficile that don't produce toxins and are not pathogenic. So, but this gives you a very rapid test. The next slide shows you the sensitivity and specificity of these tests. So you balance the sensitivity or the validity of the test with how rapidly you actually need your answer. And the toxigenic culture is a very good one, because then you have isolated the Clostridium difficile from the stool, and you have shown that the organism actually produces toxin. But it takes 2 to 3 days, and meanwhile your patient's still having diarrhea. So it's the most sensitive and specific test, but it takes time. The cytotoxin assay is something that most labs can do. Again, the sensitivity is not quite as good. But again, it takes 1 to 2 days to actually run. So here are some very quick. The rapid, they're done instead of days, they're hours. So very nice, they're very quick. But if you notice, the sensitivity is not quite as good. Endoscopic exam, of course, is wonderful, but patient has to be prepped, but you do get your answer. But there are a lot of other problems with that. So it's very tough. You always have to remember, so the takeaway home message is that you need to test only patients that are symptomatic, and there are rapid tests, but you have to make sure that the toxin is present, not just the C. difficile. So what kind of standard treatments are there? It's very exciting to be involved in Clostridium difficile research recently because we're developing new drugs and they're being approved by the FDA, the Food and Drug Administration in the United States. And these are our 4 major standard treatments for C. difficile. Metronidazole, of course, is not approved by the FDA, but is used very much. The initial response time is good, 94%. But the problem is that about 20 to 28% of patients actually develop another recurrence. And once you have another recurrence, a subpopulation of those people go on and they recur and they recur and they recur. You'll be seeing these patients for years and years and years. You get to know them, you get Christmas cards. I mean, these are very difficult people to actually treat. Vancomycin is actually a very effective antibiotic. It was approved by the FDA way back in 1980. It does a very good job of initially curing people from the symptoms, but again, about 20 to 25% recur. So you still have this problem with recurrence. Fidaxomicin was recently approved in May of 2011. It's another antibiotic. It was targeted to reduce the recurrence, and it does a remarkably good job. It's not quite as good for the initial treatment of the symptoms. And then an interesting twist, somebody said, well, instead of just giving another antibiotic, which is just going to disturb your gut flora, which is going to cause more dysbiosis, which is setting you up for another recurrence, let's look at the Zinpavla is a monoclonal antibody that you can give, interestingly, once to a patient, and it does significantly, it forms antibodies to toxin B, and the recurrence rate goes down also, better than vancomycin. But still, you are left with this residual of less than 20% now, but a certain segment of your patients are going to continue to recur. So I think we have continued research that needs to be done on treatments for C. difficile and interfering with the process along the way. So these patients that have recurrent C. difficile, they're a little unique, and we have to try to treat them a little differently. And so what are some other treatments for recurrent C. difficile? Chris Serraris in 2013 did a very nice study where she looked at what's the effect of looking at vancomycin. So usually vancomycin is given for 10 days and then you stop and hope the person doesn't recur. So the idea that it actually takes time, what happens is that C. difficile has very persistent spores, and the spores will happily sit in your GI tract, swimming in a sea of vancomycin, and it just waits until you clear the vancomycin, and it's like, oh, okay, the gut is still disrupted, so I have a window of opportunity. I'm going to germinate and cause a recurrence. So the idea would be, well, what happens if we take vancomycin and we extend it and we taper it slowly, taking the dose down? And then that will allow the GI flora to kind of recover. And then we stop the vancomycin and give 1 dose every 3 days. And so it's like taking weeds out of your garden. You're allowing the spores to germinate, but before they get to a level that you have a high enough level for your toxins to cause disease, you hit them with another shot of vancomycin. So it's always this balance of trying to kill the vegetative cells of C. difficile and allowing your normal flora to recover. So another idea is to also look at fecal microbial transplants, which we'll be talking about a little later today. And this is always, people recognize that the microbial flora is very complex and there's a lot of interactions, and the idea that you can just give 1 or 2 organisms to kind of restabilize is good in theory, but people are going, well, what happens if you can if the problem is that the microbial flora is disrupted, let's just give them some healthy microbial flora and then hope that repopulates that person and see if it works. It's interestingly there's been a lot of case series that have reported people have done this, and it has a nice 90% treatment rate, and it does reduce the recurrences. But I think we need to do a lot more work with standardizing the fecal flora, and we'll talk about that later. But it's another strategy, and you get about 85% cure. This was a summary rate. If you're interested in that, I would read that study. And 1 to 2 infusions seem to work quite well. You can also provide the patients with probiotics, and those are an adjunct. So you don't give them instead of vancomycin or metronidazole, but you give it with vancomycin or metronidazole. The probiotics, the nice thing, they're living organisms. They usually have multiple mechanisms of action. That Saccharomyces boulardii is a yeast that actually produces a protease that it directly attacks Clostridium difficile toxin. Why, we don't know, but thank you, we'll take it. And it also helps the normal flora to recover. Other probiotics have been studied for Clostridium difficile infections, and we get a nice response, but it's not the 90% treatment without prevention of recurrence that we're sort of aiming for. The toxin binders, with the idea that if you're able to soak up the toxin that's within the stools, then you might be able to prevent the disease. And again, they're not quite as effective. Only 64% have been cured of the recurrences. So those are the 4 major plants that have the most information and research on it. But there are investigational therapies. It's a very active area of research. If you're interested in research, I would recommend you look at different ways that you can treat Clostridium difficile. There's a lot of research that's going on. Some of them not so well, some of them better. So treatment remains a challenge. So what's the best way to actually take care of Clostridium difficile? Not waiting until the patient actually has disease, but trying to prevent the disease. This isn't, with any disease that we want, the best strategy is to prevent the disease from starting. So the challenge is that the risk factors that increase the risk for C. difficile are very common and they're hard to change. People age, can't do anything about people getting older. They have hospitalizations, they have comorbidities. The treatments of C. difficile are not 100% effective, so we need that factor is kind of important. The recurrences can actually cause new cases and cause outbreaks, and we still can't predict when outbreaks are going to occur. Some hospitals, it occurs in large hospitals, it occurs in rural hospitals. They can have good infection control programs and still have outbreaks. The advantage of looking at the prevention of C. difficile is that we know very much about how Clostridium difficile is transmitted. Multiple strategies are available to actually prevent C. difficile, and infection control practices are probably our best strategy to try to control C. difficile. But we're also looking for very exciting and innovative methods that are in progress. So the transmission of C. difficile, the sources this is the challenge, is that we have our typical hospital room, we have an infected C. difficile case, and interestingly, even asymptomatic carriers of Clostridium difficile shed spores into the environment, and we've been able to show through strain typing that it can be transmitted to somebody that will go ahead and actually develop disease. So you have 2 patients in the room, both of them receiving antibiotics. One of them is an asymptomatic carrier, and one of them comes down with disease. And it's hard to predict who's gonna win the lottery. So we're still working on that. But again, the same problem is that it's also C. difficile is found in animals. It's found in soil. We found C. difficile in the soil outside of our hospitals. I found C. difficile in my backyard. So it's everywhere. Oh my God. And the vectors are very common. So C. difficile has these wonderful spores, produces them. They're very persistent to normal disinfectant agents. They are shed. They're all over the hospital environment. So pretty much anywhere people touch can be contaminated with C. difficile. Hands of not only staff and patients, but your visitors. We've actually shown that they acquire C. difficile in their hands, and other patients. So again, hand washing is very important. We've been able to show that the spores of C. difficile can persist for over a year in the same hospital room, even though it's been cleaned and people have gone and said, oh no, everything's fine. Still go back there with our trusty little cotton swabs and find the same strain of C. difficile persisting in the hospital ward. So it's very clever. So how do you prevent this from being transmitted? So one way is to actually focus on infection control practices. And there are since it's transmitted by the hands, one thing has been saying, most of the hospitals in the US have alcohol hand rubs. And in Mexico, how many hospitals have those alcohol things? How many things that's good for C. difficile? Oh, okay. It actually has no effect. This is an effect of looking at Clostridium difficile rates. You use alcohol hand rub. Why? Why something, you think you're doing a good job by using alcohol hand rubs. It's great for eliminating staph. It's great for enterococci, but the problem with Clostridium difficile, if you're a microbiologist, you know the answer to this question, because how do we actually stimulate the spores of C. difficile to germinate in the lab? We give them an alcohol shock. So it actually helps the spores to germinate. So going back to what mother always told you, wash your hands with hand soap. You know, you can use gloves, but recognize that it's the physical removing of the spores that are not going to be killed by the soap or the alcohol or whatever. So even though you put a lot of these alcohol hand rubs, interestingly, the level of staph infections went down, but not Clostridium difficile. What happens if you go, okay, so the spores are the environment, so we're going to put an intervention. Here's C. difficile rates before. It was pretty high, and this is a composite, the mean of 7 hospitals. They started an intervention where they really focused on education and making sure that rooms, when the patient was discharged, was thoroughly cleaned. Did it have effect? Absolutely nothing. It's like, oh, okay, so you can clean your rooms, but it didn't really help. So what about if you look at antibiotics, another risk factor? Here is when you do a single preventive intervention, you actually see a reduction of Clostridium difficile infections. They restricted the use of fluoroquinolones and cephalosporins, and they actually saw a reduction of Clostridium difficile. So the best way to actually prevent it is to use what's called infection control bundles. And unfortunately, there's not a standardized bundle that works best for different things. And different people, different hospitals have different components. But early detection, hand height, the ones that are in bold are actually the ones that are the most effective. So hand hygiene, not with the alcohol. Personal protection equipment, so gowns and gloves. Cohorting or isolating your C. difficile, so if you can detect them very early and then put them in a private room or another room that has an infected C. difficile patient, that helps to removing them from the general population. But again, you have to have, your hospital has to be set up for that, and and it's expensive. Education programs by themselves don't really do much. Environmental disinfection is important. And antibiotic stewardship programs are really very important also. So if you use infection control bundles, you can reduce your C. difficile rate by 45 to 85%. But you still have C. difficile. So quickly, what are some innovative measures that we're using now to trying to prevent C. difficile? The use of probiotics on a patient level. So as a patient comes in and receives antibiotics, you prescribe a probiotic to go along with that. Probiotics are actually being used on a facility level. So every patient that comes into the hospital gets a probiotic along with their antibiotic. And so that way you don't have to go, well, is this person at risk? Should we give the person a probiotic? You know, which one should we give? And the more decisions you have to make along the way, the longer it takes to get the patient treated. So some hospitals had said, okay, I'm just going to give every patient that gets an antibiotic the same probiotic and see that it works. And actually some vaccines are being developed. There's problems with the vaccines, and again, you wouldn't give everybody a vaccine, but you'd have to be able to identify the high-risk population and then give them a vaccine, but you have to allow time for the antibodies to be developed. So I think that's not quite a viable candidate, but it is being worked on. And then quickly, this is just another take-home message is that not all probiotics are created equal. If you're going to prescribe your patient a probiotic, make sure it's a probiotic strain that is effective for C. difficile. So this meta-analysis looked at, these are 4 different probiotics that are good for Clostridium difficile. You'll find Lactobacillus GG, which is a very common probiotic, is not effective. And then on a prevention, I urge you, if you're interested in using a probiotic on a facility level, to read this paper. This is what the Canadian hospital that had the huge hypervirulent outbreak, this is how they have controlled their outbreak. And encouragingly, not only could they reduce the outbreak, they stopped the outbreak, but they have been using this is a mixture of 3 different types of lactobacillus called BioK. They've been using this and they reduced the Clostridium difficile level. They've been using it for 10 years and the level has remained very low. And the hospitals around them that are still treating Canadian patients, but don't use the probiotic, their C. difficile rates have increased. So very innovative and exciting way to do this. So in conclusion, C. difficile is a continuing problem. The improvements in diagnostic tests is really wonderful because you can get a quick answer and they're accurate. Standard antibiotics still have about a 20% recurrence rate, so it's still a problem. The treatment of recurrent C. difficile may require different strategies than the patient with the initial episode. And the prevention of C. difficile is the key to actually controlling this disease. So thank you very much.
Muchas gracias.